We are going to go ahead and get started. Thanks for joining the webinar today, the first in a series of primary care and public health webinars. Before we get started with the presentations, we're just going to do a couple of sort of framing pieces. So today's webinar is on population health. What does it mean? And we are joined by excellent presenters from public health agencies who are going to talk to us about that. We definitely want to hear from everybody who's on the phone line today, but because there are 90 people registered and 25 of us here and growing, everybody is on mute. So definitely want to hear your questions or your feedback. So if the presenters ask a question, would love to have you chat in and respond. You can do that via the questions pane at any time during the presentation. Feel free to go ahead and write those in. No need to wait until Q&A. This webinar is hosted by the Patient-Centered Primary Care Institute, which is a public-private partnership that started in 2012 with the support of the Oregon Health Authority and managed by QCOR. We partner with experts to get technical assistance, information, resources, training, and support out to primary care practices working on the patient-centered primary care home or medical home model of care. Surely, if you've joined the webinar today, you visited our website, which is pcpci.org, and I'd encourage you to poke around there if you haven't already to see all the resources that are available. We have more than 30 webinar recordings available that feature presentations and speakers from different parts of Oregon on a bunch of primary care transformation-related topics. So please do take advantage of those resources that are available. We do actually host a resource orientation each month. It's just a 30-minute orientation where we walk small groups of people through the website resources, and you can find information about that orientation on the website if you would like a guided tour of Institute resources. As I said, this is a partnership with the Oregon Health Authority to get technical assistance resources out to folks working on the PCPCH model. The PCPCH model is how Oregon recognizes patient-centered primary care homes. There are a set of 33 standards by which clinics are recognized, and you can read more about the standards at primarycarehome.oregon.gov. And I am so thrilled to introduce our webinar presenters today. We have Cara Biddlecom, who serves as the Health System Transformation Lead in the Oregon Health Authority's Public Health Division. In her role, she works to connect public health to health system transformation efforts and enhance the performance of the public health system so it can be a strong foundation for the delivery system's goals of the triple aim. Cara's worked in public health for more than 10 years, with prior positions in HIV and STD prevention and chronic disease at the local, state, and national level. We are also pleased that Maggie Sullivan was able to join us. Maggie is the Executive Director of the Healthcare Coalition of Southern Oregon, which is a unique partnership of public health agencies and community health centers in Douglas, Josephine, and Jackson counties. Maggie serves as Project Director for a multi-county preconception health campaign, which she's going to talk to us about, a federal Healthy Start project, and a Southern Oregon Regional Health Equity Coalition. Maggie has a master's degree in public health and more than 25 years of experience in community and public health work with a focus on maternal and child health, reproductive health, and community engagement. We are also joined by Caitlin Dickinson, who is with the Oregon Rural Practice-Based Research Network. And after we learn about population health and what it means, Caitlin's going to share an opportunity for folks to join a project to improve population health. So stay tuned to the end of the webinar for that. So with that, I'm going to go ahead and turn things over to Cara.
Great. Thank you, Kate. And thanks so much for this opportunity to kick off this webinar series. We're really excited about the opportunity to talk about ways to connect primary care and public health over the next couple of months. So the title for our webinar today was Population Health, What Does It Mean? And just to kind of kick it off, there are lots of different ways that us working in health and healthcare define population. So I'd invite those of you on the phone to kind of chat in, how do you define population? In the role that you have, what does population mean to you?
So folks can chat in answers or into the question pane what population means to them. Hopefully everyone's had their coffee this morning and we're ready to answer such tough questions. All right, we had someone share using data to reduce variability. We had someone say that the people we work with. We had someone say patients, people in the community. Someone specified for our clinic impaneled patients.
Mm-hmm.
Surely there's some other A+ students. Distinct populations with distinct needs.
Great. Does that cover what you have, Kate?
That covers, I think, yep. I think I got everybody.
Okay. Great. So you're all smarter than me because what I was going to cover you already have here. So yeah, a population can mean a panel of patients, as we talked about. It can also mean members of a particular health plan, so that could be a population. And it can also mean everybody in a specific geographic area or you know, again, a group of people not defined by a particular panel or a health plan membership. So from a public health perspective, though, we really use the term population health to mean the health outcomes of a group of individuals. So that can mean an entire nation, a state, a community, or a specific subpopulation of individuals. And I just wanted to bring this up because oftentimes when we're working together across kind of healthcare and public health, it can get a little bit confusing when we talk about population and exactly what we mean. None of these definitions are right or wrong. They're all correct, but it's just good to kind of get a general understanding of what we're talking about before we start working together. So what does public health do? You'll recognize probably some of these photos in terms of what public health does, and that's to monitor the diseases and health behaviors of the entire population again. So there are three main public health functions, and those are assessment and monitoring of the health of communities so that we can identify health problems and priorities, formulate public policies so we can solve identified local health problems, and we work to assure that all populations have access to appropriate and cost-effective care, which includes health promotion and disease prevention. Another way to look at population health is this, what's called Frieden's Pyramid. So this is a framework that was developed by the director of the Centers for Disease Control and Prevention. And it lays out sort of all the different factors that go into what makes somebody healthy. So at the top of the pyramid, you'll see things like counseling and education. So that's helping your patients, you know, get advice on how to live healthy, quit smoking, get vaccinated. And then we have clinical interventions. So those are things like prescribing medications for high blood pressure control, cholesterol, diabetes, et cetera. And then we have long-lasting protective interventions. So those are things like, you know, getting an immunization or getting an intervention to help you quit tobacco. And then sort of in this second to last rung of the pyramid, you'll see changing the context to make individuals' default decisions healthy. And this is primarily where public health works. And again, as Kate said, sort of what public health does is support the clinical work so it can be most effective. And so we focus on things like creating policies so that people's communities are as healthy and supportive of their health as possible. So things like tobacco-free policies, school entry policies related to immunizations, et cetera. And then finally, we do know that what ultimately influences people's health the most are socioeconomic factors. So things like access to high-quality education, employment, poverty, housing, et cetera. So here's an example of sort of the intersection between the work of primary care and public health, and I'm just wondering again if folks could chat in and identify on this map here some of those intersections between work that happens in the clinic and what happens in the community, and perhaps ways that there's synergy between both of those fields of work. And Kate, I'll ask if you could kindly read any responses that you get in through the chat box too.
Happily. So someone wrote healthy food choices.
Great.
Social services. And exercise.
So those are all great responses. I think what we're trying to get at with this graphic is how what you support your patients to do to live healthy can be supported by what public health does in the community when they leave your offices. So when they go out and there are bike lanes for them to be able to bike instead of drive a car, or tobacco-free environment. So if you're telling them to quit smoking, they're again encouraged to not smoke once they leave your office, et cetera. So really just identifying all the different ways that we do intersect to support patient health. Kate, was there anything else you wanted to add from the chat box?
Just one more, access to care and working with schools.
Great. So just in terms of how some of this can more directly relate to the PC/PCH standards, public health does a whole lot of work to promote the uptake of recommended preventive services and screenings. So we do a lot to help promote adolescent well visits, cancer screenings, family planning services, and prenatal care. These are, of course, all related to the CCO incentive measures as well, so we do quite a bit to help support those and can really help bolster the messages that you give to your patients in the clinic. So we do large-scale social marketing campaigns. You'll see a couple of examples here from our Cancer You Can Prevent campaign, which aims to normalize colorectal cancer screening and get people in for screening. We've also done other social marketing campaigns to promote preconception health. You'll hear a little bit more about that topic from Maggie in just a bit, and also to dispel myths about birth control. So we offer tools that can help the healthcare system when folks are outside of the doctor's office. So again, we're kind of reinforcing the messages that you're giving your patients when they're in clinic. And we also offer tools to providers to help remind their patients about routine clinical preventive services. So for example, our alert database logs immunization records. You can use that to do proactive outreach to individuals who are due in for an immunization or to check their records. So some more specific examples of ways that you might be able to work together with public health. Health departments can help provide specific immunizations if they're needed in your community. Public health can in turn refer anybody that they might see to your clinic as a primary care home. You can also work together, and somebody did just bring this up with the photo a couple of slides ago, coordinating with school-based health centers to help provide the best care possible for our young people. And also referring patients to public health for some non-clinical services. So public health sometimes will be the provider or supporter of health education workshops or home visiting services that can, again, help your patients achieve optimal health and reinforce all the work that you do with them in the clinic. So some of the other things that public health does that can help support your work and particularly your progression towards the PC/PCH standards. We do support evidence-based chronic disease self-management programs. I think you'll hear a bit more about these as we continue in the webinar series. But things like the tobacco quit line, so helping individuals quit tobacco. We help support evidence-based chronic disease self-management program called Living Well that's for individuals who have one or more chronic conditions. We do some focused work on preventing diabetes, promoting exercise, helping to prevent falls through programs that are designed to support balance and physical activity. So some of the other ways that we do kind of think about the intersection between community and population health and kind of the clinical work that happens are the different ways that we implement activities that reinforce each other. So public health, again, kind of working in the community, we'll work on policy solutions. So for the example of tobacco prevention and control, we'll do things to help increase the price of tobacco, limit youth access to tobacco, and create more tobacco-free public spaces. And then at the clinic level, providers are extremely instrumental in giving their patients advice to quit. They can do this in a really great way by getting some training on how to provide cessation counseling. They can refer patients to our tobacco quit line, and they can make their tobacco or their clinic campuses tobacco-free. Another example of kind of that synergy between population health interventions and what happens in the healthcare system is with opiate overdose prevention. And so this is a really hot topic in Oregon. It's of great interest to a lot of folks. And some of the things that public health can do are helping to prevent opiate-related overdoses through distributing naloxone to individuals who might be at risk of overdose, creating laws to help promote people calling 911 if they do witness an overdose, and doing, again, kind of social marketing campaigns that can help educate the public about some of the dangers of prescription opiates and also what alternatives there might be to help them be healthier. And then again, at the health system level, some of the things that can also address opiate overdose are things like standardized prescribing guidelines that can be used across providers and hospitals, or even co-prescribing naloxone with opiates to help prevent overdoses. So with that, I just want to switch gears and kind of bring your attention to another piece that I think will better help our state understand the role of public health, and that's an initiative that is underway in Oregon called Public Health Modernization. So there was a task force that had been developed in 2014 that provided some recommendations to the legislature on how to modernize Oregon's public health system. Those recommendations that were developed over a period of 9 months were used to develop House Bill 3100, which passed the Oregon legislature back in July. So this bill basically adopts a framework, which I'll show you in just a minute, of exactly what public health has to provide across every single jurisdiction in the state. It makes the public health system accountable to the Public Health Advisory Board, which is operating under the guidance of the Oregon Health Policy Board. So sort of at a policy level, making sure that public health is a part of our health policy board's purview as well. State and local public health authorities will be working to assess their ability to provide these core services, which you'll see in a moment, and then we'll be submitting a report on how we're doing on that to the legislature this coming June. So just to quickly demonstrate to you what public health in the state of Oregon will be responsible to do in the coming years is what's identified in this graphic. This was developed from the Institute of Medicine's 2012 report and also follows along with some work that other states, including Washington, Ohio, and others have done. So we're kind of helping to lead the nation in adopting what public health should be doing. And in this graphic, you'll see a set of foundational capabilities. And so these are the things that we use in order to implement the foundational programs that are pictured there. So essentially, this means that all governmental public health agencies in Oregon would be providing at least a baseline core public health service to everybody. And then there might be additional things that they do in their communities based on local need. You'll see there one of the programs is access to clinical preventive services. And this one, just to kind of clarify for your role, means that public health would be helping to collect data and information on who has access to clinical services and making sure that all populations do have access and that they're getting plugged into providers such as yourselves for the care that they need. Not necessarily that public health is providing those services directly. So what does this mean for you? Again, we're hoping this will mean greater consistency of public health services across all regions of the state. It also means that there's more flexibility in determining local health needs. So again, every jurisdiction has to provide a core service, but then those additional services can be customized based on the needs of a particular population. We'd welcome your involvement in future initiatives as related to public health modernization. So here's our website, and you're welcome to contact your local health department about this work as well. So with that, I'm going to pass it over to Maggie, who's going to provide some really concrete examples of some of the work that she's done in Southern Oregon between public health and primary care.
Thank you, Cara. So this is Maggie Sullivan. I'm based in Medford, Oregon at the very southern end of the state and working in a 3-county region to implement a preconception health campaign, working very closely with both public health and community health centers. Okay, here we go. So I am a part of the Southern Oregon Perinatal Task Force, and we have a community partnership going between public health agencies, community health centers, coordinated care organizations, early childhood programs, and various other community groups for a preconception health campaign in our region. So this consortium was really, really key. Getting the partnerships going was very key to our success. So in our Perinatal Task Force Consortium, we have public health agencies from 2 counties, coordinated care organizations from those 2 counties, community health centers, federally qualified health centers, as well as private clinics, dental clinics, including Advantage Dental and All Care Dental, drug and alcohol treatment facilities, early childhood programs, Head Start, Healthy Families America, our Early Learning Hub, and a university partner in our region, OHSU School of Nursing. So our consortium was formed in the 1990s as a Jackson County Perinatal Task Force, and it was the public health director that formed that and did reach out to partners in primary care and community health centers. In 2008, Josephine County formed its own perinatal task force, and in 2012, as healthcare reform kicked in, the 2 counties merged and pulled in the managed care organizations, coordinated care organizations, to really focus on perinatal health in our region. The Perinatal Task Force developed a mission statement to really focus our work, and the mission was to improve the health and well-being of pregnant women, infants, and young children by empowering women and families to make healthier choices for themselves and their babies before, during, and after pregnancy. There was a series of brainstorming and priority setting sessions, and the group focused on preconception health as the unanimous priority issue and where we wanted to focus attention. We looked at literature reviews, we got input, and we brainstormed, and it was quite unanimous. With healthcare reform, there were some new funding opportunities, and we went ahead and applied to a Oregon Health Authority Community Prevention Grant, which was focused on clinical preventative services that linked public health with clinics. And we received funding. It was a state innovation model grant originating from the Centers for Medicaid Innovation. The fiscal agent for this project was our public health department, and our nonprofit organization took on the project management. So the need for a preconception health campaign with a very strong focus on both contraception and preconception health is compelling. Half of all pregnancies are unintended, and over half of deliveries in Oregon are paid for by Medicaid. You'll see the pie chart with the statistics from the Guttmacher Institute. We know that most unintended pregnancies are unwanted or mistimed, and most could be prevented or better timed with improved access to contraception. And many unintended pregnancies are wanted but could be better prepared for with access to contraception care. Unintended pregnancy is associated with multiple health issues for both mother and infant, including preterm birth, low birth weight, increased infant mortality, delayed prenatal care, increased depression, anxiety, and physical abuse. So we figured if we could really focus on preconception health screen and implement contraception and preconception care, that would be huge. So we looked for some sort of evidence-based intervention which was quick, which was feasible to do in a primary care visit, wouldn't take too much time, and landed on the evidence-based clinical intervention, the one key question. All women aged 18 to 50, and actually we're asking some as young as 13, they're asked as a routine part of either a primary care visit or any health visit, would you like to become pregnant in the next year? The question is tested. It's not, are you planning to become pregnant? It's, would you like? It's non-judgmental. It gets at what a woman wants, not what she should be planning according to perhaps the unintended or the perhaps judgmental tone that might creep in when a provider says, are you planning to become pregnant in the next year? It's just very open-ended. Would you like? What would you like for yourself? This question was developed by the Oregon Foundation for Reproductive Health. Michelle Stranger-Hunter, we give kudos to this organization. They've provided extensive technical assistance and have really helped us launch this throughout our community. There's an algorithm, a very clear algorithm that goes with this pregnancy intention screening question with very specific questions, follow-up based on whether the answer is yes, no, okay, either way, or unsure. As we launched this pregnancy intention screening, we developed a template form, a very simple one-page form that could be used in WIC public health clinics, at Head Start programs, home visiting programs. This was used by WIC intake workers, home visiting staff, and it was really a half-page question. You'll see this is both English and Spanish. Would you like to become pregnant in the next year? Whether the answer is yes, no, there's a couple simple follow-up questions, and it can take as little as 3 to 5 minutes. The form was then put in the chart, and we compiled and looked at the data we got from this. One key question has also been embedded in multiple electronic health record formats, again with a template to follow so that when health workers are doing their intakes, there's a clear protocol to follow so that it will remind them to actually ask the one key question and to document and chart what the responses are. So in response to the one key question, would you like to become pregnant in the next year? If the answer is yes, the indication is some preconception advice and care. Screen for conditions that could affect pregnancy, a medication review, counsel on nutrition, exercise, or substance use, recommend folic acid daily, recommend early prenatal care. This would be the protocol in a primary care setting. When this question is asked by a home visitor or in a WIC setting, they may not have the medical background to do the medication review and some of the other screening, but they could certainly recommend folic acid and recommend prenatal care. If the answer to the one key question, would you like to become pregnant in the next year, is no, the indicated education is about contraceptive services. Asking about, are you currently using contraception? Are you satisfied with your method? Do you know about long-acting reversible methods like the IUD and implant? Do you need access to emergency contraception? If a client answers that she's okay either way, the follow-up is to ensure that she's prepared for pregnancy. If she's ambivalent, there's a pretty good chance that she could end up pregnant. Recommend preconception counseling and early prenatal care. For clients that are unsure, the follow-up is a combination of contraception and preconception care and discussing the ambivalence about relevant issues, and if not using contraception, to act pregnant before you become pregnant. Many women are unsure or ambivalent about their reproductive health intentions, especially if they've never been asked. So primary care, WIC, home visiting situations are perfect to start that conversation about pregnancy intention. Is now the right time to become pregnant? Do you have the resources you need for a child or for another child? How would having a child impact your family, education plans, financial status? And then the follow-up for women who are ambivalent is the motivational interviewing approach. Using the 1 to 10 scale to gauge ambivalence, or asking, how important is it to you to prevent pregnancy? Why would you say, if you say 3, why would you say you wanted a lower number? Why do you think your number might not be higher? I hear you have mixed feelings, but it's something you're thinking about. How can I help you? And then again, the follow-up responses for someone who's ambivalent would be, I would recommend you choose a contraceptive method to protect against pregnancy until you're sure. You know, the education message, I want you to know that in a year's time, 85 out of 100 women who have unprotected sex will become pregnant. What would you like to do? How can I reach your goal? How can I help you reach your goal? So the health outcome measures that we have been tracking when we can, or that we're looking at carefully to see if pregnancy intention screening is making an impact, is early entry into prenatal care. We're hoping that by asking about pregnancy intention, if we hear ambivalence or a yes, we can ensure that women, wherever they, if they're at WIC, if they're even at a dental clinic, that they get a referral to a prenatal care. We're looking to impact teen pregnancy rate, teen birth rate, unintended pregnancy rate, and contraceptive use rate. A very important public health strategy that pregnancy intention screening can help achieve is removing barriers to contraception. So while we've been doing, rolling out pregnancy intention screening in every setting we possibly can, we're also providing education for both providers and the population regarding Oregon Health Plan's coverage of all methods of birth control and how and where to obtain them from CCOs. We've worked with Oregon Foundation to do advocacy work to local CCOs to ensure that all methods of birth control and at least 3 months supply of birth control pills are available. About a year ago, when we were hearing back that some of the CCOs in our region weren't providing everything, all methods, and we were able to connect with their policy people and let them know that that was not legal according to the Affordable Care Act, that they must provide all methods, and that if they did not, we were going to follow up and create, follow this up and ensure that that was happening. And then client education on the effectiveness of methods as well. There's some wonderful client education materials from Bedsider. Here's an example of a very health literate, easy to read birth control metric chart that lists the most effective methods first. They've got other great materials as well, and we've handed these out extensively to all of our sites that are doing the one key question so that they can give their clients some educational materials as they talk to them about birth control. Another important public health strategy is to improve the availability of and increase referrals for LARCs, long-acting reversible contraception. We worked to develop a referral grid to show both providers and clients where they could go to get contraception. We provided educational materials, and we've been doing annual contraceptive update trainings for both providers, clinics, and including training in the insertion of IUDs and implants. The Oregon Office of Reproductive Health has been wonderful about helping provide trainers at little to no cost. We actually have a training coming up next month in partnership with UCSF. University of California, San Francisco has a great free IUD and LARC training that's coming up. Here's an example of the family planning referral grid. It's been extremely helpful. We simply looked and found all the sites in our community that were doing family planning, and then we categorized which ones were providing Title X, which ones were providing C-Care, who served Oregon Health Plan, who took private insurance, and what methods did they provide. We put a little definition of what Title X is and who's eligible, what's Oregon contraceptive care, who's eligible, what are the income guidelines. And our providers have said this is great because then they can actually even set up an appointment for a woman or just help her make that call if she's not using birth control and link her to the appropriate site for, if she needs Title X because she's an undocumented woman, to tell her that Title X cannot refuse services and here's where you can go to get an IUD, even if you don't have Medicaid. So again, LARCs, education on IUDs and implants. We also know that it's very important to look at data and do quality improvement. so our quality improvement plan was to look at the biggest volume of women being screened was in our WIC clinics. Our Jackson County WIC clinics screened 300 to 500 per month because there's that many WIC visits. And then we were able to compile the data and look back at it. So here's just a 1-month snapshot from Jackson County WIC, November 2014. Would you like to become pregnant in the next year? 255 women answered that. The majority, about 55%, said no, and for a number of them it wasn't applicable, and close to 10% said yes. Of those who said yes, they would like to become pregnant, the follow-up question, very important, was, are you taking folic acid or a multi or prenatal vitamin? The majority of them said no. So what a wonderful opportunity to jump in right there and say, wow, it's really important for you to be taking folic acid before you become pregnant and in your early pregnancy. Here's some, I've got a starter bottle of folic acid for you right here. Let's get you set up with that right now. I mean, a basic preventative public health strategy that can be implemented right away. For among women who answered no, they would not like to become pregnant in the next year, the follow-up question is, are you using a method of birth control right now? And one reason we did the quality improvement is we found that some of the WIC workers asked, would you like to become pregnant? And when they said no, they didn't ask this question, are you using birth control? What a missed opportunity if you don't take advantage of women right there in front of you to ask, are you using birth control? We saw that about 25% of women who said they did not want to become pregnant were not using birth control. The WIC worker could walk them right over to the family planning part of the health department and set up an appointment right there and then, or work with the referral grid to get them linked up somewhere where they could get birth control. And then if women said yes, they know they don't want to become pregnant, and yes, they are using birth control, the next question is, well, are you happy with your current method? About 15 to 20% said no, they were not happy. If a woman's not happy, she's likely to have an unintended pregnancy. So again, an opportunity to get them linked to something more effective. So one key question, pregnancy intention screening, we've been very successful in getting it embedded throughout the community. We've found that it's quick and it's pretty easy, and the sites where we're implementing have said they really do see that it works. So we have it implemented at the WIC program in both Jackson and Josephine County Public Health. It's embedded as a protocol in the Family Planning Department of both Jackson and Josephine County Public Health. It is done across the board for both Head Start and Early Head Start in Jackson and Josephine County, and we're just unrolling it with the Head Start in Douglas County. It's part of the Healthy Start of Southern Oregon plan for Jackson, Josephine, and Douglas County. Just this summer, we worked with Advantage Dental, a dental clinic, and they really saw the linkages between preconception health, dental care, and so for their intakes, all Oregon sites, there's multiple clinics, they have asked that one key question, would you like to become pregnant? So in a dental office where healthy young women of reproductive age show up every day, there is the pregnancy intention screening is there and the opportunity for education and referral. Our local federally qualified health centers, Siskiyou Community Health Center Rogue, La Clinica, our Healthy Families America Home Visiting Maternal Child Health Program. All of these sites are implementing the one key question. The outcomes at community health clinics, about 30% of women needed follow-up with contraception or preconception care, and about 70%, they knew really clearly they did not require follow-up. So this is our point. It doesn't have to take a long time. The majority of women that you screen will be set. It's that 30% where you can make a huge difference. At public health clinics, 60% of women were happy with their current method of contraception, but 23% received new and many times more effective contraception, and 12% were given preconception care and advised to start folic acid. So great public health preventative strategies implemented by this screening. So the biggest barrier, perceived barrier I should say, is won't it be too time intensive? We do so many screenings. Isn't this one more thing? And our pilot showed that one key question screening is feasible in a primary care visit, a home visiting session, a WIC appointment, even a dental appointment, and it's acceptable to women, even at non-reproductive health visits. I think our biggest hurdle was working at first with the health workers who thought, well, wait a minute. They're here for, I can't talk to them about reproductive health. They're here for something else. Women are often happy. They want to talk about it. They sometimes don't know how to bring it up, and they look to their providers to do so. Only about 30% of women are going to need follow-up care. And if a woman doesn't want to become pregnant and she's not linked up with birth control, that is essential, very important, well-spent time to do that. This one key question screening helps meet the PCPCH metric around providing gender and appropriate services for contraceptive methods in counseling and folic acid use. The screening methods are adequate to meet this quality measure. It also helps meet one of the CCO metrics for effective contraceptive use among women at risk of unintended pregnancy, which became incentivized just this year. So just as an acknowledgement, if you're interested and want to learn more about implementing pregnancy intention screening, such as one key question, the Oregon Foundation for Reproductive Health is wonderful for technical assistance. They have an implementation manual, clinic and staff inventory, lots of algorithms for how to embed it in various settings. They do custom consultations around clinic flow, data collection, and additional trainings for providers, wonderful patient brochures and posters. And I'm going to, here's this slide with the contact information for their director and their staff. We wouldn't have been able to make this happen without their amazing assistance. If you want information on how it went in our community or any, we'd be happy to share our stories, any of our materials. Here is our local staff. Thank you very much.
Great. So we're going to pause for a couple minutes for questions. So again, if you have questions for either Cara or for Maggie, please go ahead and write them in now. So this is sort of your reminder to type those into the questions pane. I know the one question that we usually get is, will the slides be available? And the answer is yes. And the slides will be available and posted to the website along with the recording by the end of today. If you have any other questions, please feel free to write them in. And while we're waiting for folks to do that, we're going to go ahead and turn things over to Caitlin Dickinson, who's managing a project at the Oregon Rural Practice-Based Research Network, and here to tell you about an opportunity that primary care practices have to join a public health campaign to improve care in a different way and improve the health of their patients through this project. So Caitlin, welcome.
Thank you very much, Kate. I really appreciate that introduction, and thank you to both Cara and Maggie for such a great presentation on both the kind of spectrum of work that's being done in public health throughout Oregon, and then some specific projects that are conducted in the southern end of the state that was really exciting to hear about. So I wanted to share a project that we're working on at ORPRN. Like Kate mentioned, ORPRN is the Oregon Rural Practice-Based Research Network. We're a part of the Oregon Health and Science University, a little department that's located down on the waterfront next to the new beautiful Tillicum Bridge. And we just started a project called Healthy Hearts Northwest. We're calling it H2N. It's a project funded by the Agency for Healthcare Research and Quality. We received funding back in May, and we are just now starting to kind of launch the project and working directly with the practices. So I'll get into a little bit more of the particulars about the project, but I just wanted to give a brief introduction to the overall initiative that's funding this work. Again, it's an ARC-funded project, and the larger parent project is called Evidence Now. So we're actually working with 7 different regional cooperatives throughout the U.S., and that will touch 12 states, reaching approximately 5,000 primary care clinicians and hopefully serving about 8 million people in our country to look at cardiovascular health, knowing that that is such a kind of hot topic right now in our healthcare spectrum, knowing that heart disease kills about 1 in 3 people. And that heart attacks are the #1 and stroke is the #4 cause of death in our country. So again, the purpose of the project is to work with these different regional cooperatives to help improve the quality improvement infrastructure and capacity of small and medium-sized practices. And we're helping to build that QI capacity by improving the ABCS measures. The ABCS measures come from the Million Hearts campaign that was started in 2012. ABCS stands for aspirin use, blood pressure control, cholesterol management, and smoking cessation. And the goal of this is to really prepare practices for value-based planning that's kind of coming down the pike. So we wanted to give just a quick overview of the other projects that are going on throughout the U.S. Again, we're part of the Northwest Collaborative, working with a couple partners up in Seattle, Qualis Health, and the McCall Center to conduct this work in our 3 states. ORPRN is primarily responsible for Oregon. Again, like I mentioned, the 2 partners that we're working with, we're also partnering with the University of Washington and using some of their work as a regional extension center to help recruit and find the best practices that we could be working with. As a cooperative, we're trying to work with 320 small to medium-sized practices. Within Oregon, we're really hoping to target 150 practices. So some elements of our project. We are trying to, number one, help the health IT assessment and support, and kind of give some bullets on the right-hand side about how we're specifically trying to achieve that. Is basically by generating QI performance measures and export reports, and then help the practices use data to drive improvement. A huge element of our project, probably the core of this project, and one of the core elements of ORPRN as a whole, is we're helping with the practices accomplish the QI support by using practice facilitation. So we have 8 practice enhancement research coordinators that will be located throughout the state that will be meeting not only face-to-face, but will be calling practices, maybe doing web-based meetings with the various practices over the 15 months of practice support to really give that support to the practices that they need to be able to pull the reports that we're hoping that they can at the throughout the duration of the project. Another element of the project is the evidence-based clinical guidelines. I mentioned the ABCS. Those are really the guidelines that we're focused on for this particular project. And then there's some shared learning opportunities available as well, including some bi-monthly webinars where we would be showcasing some work that either is very helpful that we've seen within the practices so far, so kind of best practices, and then also there might be some webinars targeted for specific topics throughout the project. So I wanted to just give a little bit of an overview of where we stand right now as a country with these Million Hearts quality measures. And we are asking, when we go out to meet with the practices, we're asking them to help us maybe get an idea of where they stand right now with the ABCS, and then also to compare that to the 2017 national goal. So we feel like this is kind of a powerful way to display, like, oh wait, we have a little ways to go as both a country, and from what we can pull right now as a state to reach where we're hoping to be by 2017. I feel like this slide is pretty powerful because it shows alignment with other quality improvement or, other incentive programs that various practices could be working on right now. So if practices are in SQHC, they are asked to usually showcase data relating to UDS, and so there's overlap with what we're hoping to pull from this project with what UDS requires practices to report on as well. So while it's a lot that we are asking practices to do, the chances that the practices are already actually reporting on some of this data are pretty high. So hoping that we can relieve some burden on practices for that. So I wanted to kind of give a little overview about more of a theoretical viewing of this project. So this is a slide that came from Solberg, and it was a paper that was written in 2017, just kind of looking at practice transformation and the elements of it, and the different aspects of how we are trying to improve practice transformation or help with practice transformation throughout this study and the different study elements that we would be providing to the practices. This goes with the patient-centered medical home assessment that the McCall Center did several years ago now, but we wanted to showcase the different elements of the PCMHA that we will be focused on within our project. Primarily the quality improvement strategy. We are trying to help with team-based relationships, evidence-based care, patient-centered interactions, and also care coordination. So like what Cara was describing with the different factors to affecting health, we are kind of starting in the same point where we're focused initially on some of those bottom factors like changing the context, and then eventually the hope is that the providers would be able to talk with patients and provide some counseling and education about different heart programs that may be heart health programs that would be going on in the state that could help with their care. This slide, and I'm sorry that I'm rushing through these so quickly, just trying to give a little bit of a flavor for all the elements of our project, but I wanted to show this slide because it gives an overview of the specifics that we're going to be doing with the project. So starting with these high leverage changes that are in column 2, these are kind of the, I guess, core elements that we're going to be focusing on with the various practices that we're going to be working with, acknowledging that each practice will be coming in at a different stage, so it may look different in terms of the sequence of these elements. But I think this gives a good overview for the practices and project managers and kind of getting an idea of, okay, so we're going to be not only pulling data on the ABCS measures, but we're really going to be looking at our team and defining who is responsible for being able to identify and manage our population as well. So to kind of end with just recapping, we're trying to recruit 130 practices in Oregon. We're asking those practices, are you ready for better heart health for your patients, for hands-on support and resources to help your practice with QI, and to prepare for the new payment models based on quality, not volume. And this project would allow you to get support for your practice, not only with the health IT assistance, but also with quality improvement coaching. We find this project to be very important. We're super excited about it here at Orbrin and throughout our Northwest Collaborative. These are 5 reasons why we think it is important. It helps practices be able to use their EHR to generate data reports. They are able to look at their data to identify care gaps. We're going to develop processes for improving care and outcomes within each practice. The practices will be able to report their data on a regular basis through our assistance if need be. And it really helps practices get an idea of what is coming down the pike and what they will need to be reporting and providing to their patient population in order to kind of survive in this rapidly changing or transforming healthcare system. This is a quote that we want to share with practices because we know that this is going to be a pretty intensive project on a lot of different levels. It's a 15-month project where practices are asked to provide reports on a 90-day basis and be reporting on some elements that they may not have at this point in time. But we are hoping that with the support that Orphan can provide, along with the acknowledgement that we are going to be changing our healthcare context, that we can do it. We can get through this, and it will be 15 months of rolling up our sleeves, but by the end we'll have learned a lot and hopefully be able to provide some foundational support to the practices in the changing context. So we encourage everyone to visit our website. We just got it up and running. It has a little video on there that our providers have created, and the providers that are or OHSU and the McCall Center have created, and it helps provide some more background information about the project as well. Feel free to reach out to our director at Orphan, LJ, or myself if you have any additional questions about the project, and we really hope to maybe work with some of you guys in the future.
Hi, this is Kate. Thanks to the couple of folks who wrote in some questions, so we'll try and get to those really quick before 9 a.m. today. So the first one was for Maggie. And Maggie, someone wondered if there was a method for screening results from the different agencies that you talked about, so WIC and Head Start, to be communicated to a person's primary care provider, and if so, how did that work? And if not, what sort of challenges has that posed?
I think maybe the intent, like in a WIC or home visiting setting, is to link up a woman to a primary care provider, especially if she needs more intensive preconception care. So, I guess we're still working on our 211 and our referral systems to ensure that a woman actually gets somewhere. But if she's got a relationship with a home visiting staff person or a WIC, sort of that trust relationship, it's more likely that the WIC or the home visitor can get her linked to a primary care site for more care. I hope that answers it.
Yeah, I think so. If there are any other questions, feel free to write them in. I shared the information in the chat about the Healthy Hearts Northwest project and some links to resources around one key question, and actually a blog post that the folks who developed one key question wrote for the Institute on working specifically in primary care. So there was a follow-up question to the last question. If someone already has a primary care physician, there's no sort of link back to that person from the community agencies. Is that right, Maggie?
Well, there could be. If a home visitor may already have all that information, and I guess the intent is if they haven't talked about reproductive health, someone may have a primary care provider and they've never even talked about reproductive health with that provider because they're going to see them for something else. So it's an opportunity for the home visitor to say, wow, this is important to bring up with your provider. If they could potentially somehow flag and let the provider know that this woman's in need of birth control services or preconception health. I think there's still work to be done on those linking pieces, so it's getting my wheels turning.
Oh, good. That's all we can ask for on a Wednesday morning.
Yeah.
Great. Well, thank you to everybody who tuned in this morning. Hopefully there are some resources in any other presentations that you might be able to take back to your organization. We strongly encourage you to complete the post-webinar survey that will come up after you exit, and wanted to let you know that our second webinar in the public health and primary care series is in November, on November 18th. The link to register is on the Institute website, and it is around tobacco cessation resources for that exist in public health and could be leveraged in primary care for care teams that are working on that with their patients. So hope that some of you may be able to tune into that. Thanks, and hope everybody has a great rest of their day.